Hi, my name is Dr. Jasmine Thum, and I'm an epilepsy surgeon here at the University of Alabama at Birmingham. In this video, I'm going to explain what an anterior temporal lobectomy, or ATL, is, why we recommend it, what surgery involves, and what recovery might look like afterwards. An anterior temporal lobectomy is a surgery designed to remove a portion of the temporal lobe of the brain where seizures begin. The goal of the surgery is to reduce or eliminate seizures while preserving important brain function. We consider this operation for patients with drug-resistant temporal lobe epilepsy, meaning seizures that continue despite medication treatment and that likely are coming from the temporal lobe. Based on very large studies, about 70 to 85% of patients achieve long-term seizure freedom, especially when testing shows that seizures arise from one clear temporal focus in the brain. The surgery is performed under general anesthesia, so you are fully asleep. We make an incision on the scalp on the same side that we think the seizures are coming from. We create a small opening in the scalp and remove the portion of the temporal lobe tissue responsible for generating seizures. The bone that is removed gets plated back onto the rest of the skull with small screws and plates that are oftentimes made of titanium. While these plates and screws typically do not alert at the airport, it is always a good idea to let the airport attendant know that you do have plates and screws on your skull. Navigation and imaging guidance help us plan the safest approach for this surgery. This will help us avoid any key brain structures that might be involved in vision, speech, and motor movement. After surgery, you will stay overnight for close monitoring. We obtain imaging after surgery, usually a CT or an MRI scan, to confirm there's no bleeding and that the surgical site looks appropriate. Most patients go home within 1 or 2 days after surgery, depending on their recovery. We want to make sure that you are tolerating the pain well, that you're able to eat and drink well after surgery, and that you're able to be mobile again if you were mobile before surgery. We do expect that most patients will have about a 5 to 6 out of 10 headache after surgery that likely will persist for the next 3 days to 7 days after surgery. This is normal, and we will give you medication to help you at home with the pain and the headaches, and we also recommend taking Tylenol around the clock for the first 3 days if you do not have any liver function issues. All brain surgery carries risks, and although serious complications are uncommon, these can occur. One important risk of this surgery involves speech. If surgery is performed on the dominant language side of the brain, which we will know based on your neuropsychologic testing, you might have word-finding difficulties or changes in your speech fluency after surgery, which we'll discuss ahead of time. Another consideration is memory function. The temporal lobe plays a key role in memory formation and consolidation, and some patients may notice changes in memory afterwards. Sometimes these are temporary and improve over time, and sometimes these are permanent, and we like to let patients know about this ahead of time. Before surgery, we perform detailed neurocognitive testing to help predict the risk of these complications and guide decision-making before surgery. A common visual change happens after a temporal lobe surgery, which is called a pie-in-the-sky field cut, which is a partial visual field cut in the upper outer quadrant of your vision. Most patients don't notice this unless it's pointed out to them. However, it can sometimes be bothersome for patients who play sports, especially ones that involve aerial objects, such as balls or golfing. This affects the upper outer corner of the vision on one side because the visual fibers run through the temporal lobe. Many patients adapt well to this over time. However, this is something that I do like to discuss before surgery. About 2 weeks after surgery, you will return to clinic for an incision check and follow-up planning. Oftentimes at this follow-up appointment, we will remove staples or sutures that are placed in the cranial incision. Oftentimes, if this is your first surgery, I will have placed staples. If you've had more than one surgery on that side, I'll oftentimes place sutures instead, or a combination of sutures and staples that will need to be removed. Our goal is to combine precise surgical technique, careful preoperative planning, and thoughtful recovery planning to give you the best chance at seizure freedom. Hopefully, after this surgery, your seizure reduction will be noticeable. I typically tell patients to be aware that seizure reduction might not occur within the first couple of weeks, as your brain is still getting used to the surgery having taken place. After about 4 to 6 weeks, your brain should settle down, and we should have a better idea of where your seizures will be at moving forward. If you do not have any seizures after the surgery, do not stop your anti-seizure medications unless explicitly told to do so by your neurologist. After surgery, you should continue taking all of your medications as previously prescribed. If you have any questions about whether an anterior temporal lobectomy is right for you, we will discuss your individual case in detail during your clinic visit. Please bring any questions that you might have, and I look forward to meeting you in person. Thank you very much for watching this video and for choosing UAB.